Good afternoon, everybody. My name is Melanie Escher, and I'm with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. And you have joined us today for the Arizona Telemedicine Program webinar series. So, welcome, everybody. So, we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So as you joined today, you joined with the webinar, your phone or your computer microphone was muted. Time's going to be reserved at the end for questions and answers, and please use the chat function to ask those questions. If you have a question in the middle of the presentation, please go ahead, put it into the chat. We are monitoring that. There is a post-webinar evaluation. The CME credit is only available during the live presentation. Like I said, it is being recorded and recordings will be posted on the website. You don't need to worry about copying that down right now. I will put it in an email when we are done for you. So these were sent out with an updated email, although we had quite a few people registered that did not receive this yet, but it was on the registration page. So these are the continuing medical education, outcome objectives, accreditation statement, and disclosure. The code for attendance tracking for CMEs will be found in the evaluation. And if you haven't set up your profile, don't worry about it. I will have all that information in the email after our program today so you can get CME credit. Or if you just need a certificate of participation, we can take care of that as well. We always have our disclaimer. The opinions expressed in the presentation and on the following slides are solely those of the presenter, not necessarily those of the organization sponsoring the webinar. The organizations do not guarantee accuracy or reliability of information provided herein. Standard disclaimer. And again, so we have more upcoming webinars that you can check our website. Again, this information will be in the thank you email. Your opinion is valuable to us. This is the URL link for the evaluation, but it'll also pop up in a window behind your screen that you're watching us on right now. So without any further ado, I'm going to go ahead and introduce to you today Tara Sklar. And today's session is called Prescribing in Telemedicine, Charting the Course Beyond the PHE Era. So Tara she's a faculty director of health law with Arizona Law. She's based out of the Washington, D.C. area with the University of Arizona. And she's also our associate director of telehealth law and policy with the Arizona Telemedicine Program. And she will go ahead and introduce our presenter today. Tara?
Wonderful. Thanks so much, Melanie. Welcome to all of you. We're so excited to have you join us. For those that are just coming in, as Melanie mentioned, please use the chat function if you have any questions during our talk today. I will be moderating it, and we'll have time at the end to hopefully get to all your questions. We are so very lucky to have Dr. Beju Shah join us. He hails from Charleston, South Carolina, which before the webinar, I mentioned was, I think, one of the most beautiful cities in the country. He is a highly recognized and sought after expert, especially when it comes to telehealth prescribing. He has over 25 years of experience in healthcare and technology as both a pharmacy automation expert and a thought leader. He is integral to leading a number of advocacy initiatives centered around pharmacy and telehealth prescribing regulations. Many of you on the call today probably joined because it's a very confusing environment right now with what's happening with the laws and regulations surrounding telehealth prescribing at both the federal and state levels, along with these overarching concerns of balancing risk and access to care. So we are delighted that Dr. Beju Shah could help unpack the regulatory landscape for us, as well as his insights on emerging trends. I think in particular, given he is a trained pharmacist, his thoughts on how pharmacy is changing with these technology advances and the shifting regulations. So couldn't be more thrilled to have you with us today, Dr. Shah, and we look forward to your presentation. Oh, and it's on mute at the moment, of course. Thank you.
Okay, there we go. Thank you, Professor Sklar. And I just wanted to start out by saying thanks to the Arizona Telemedicine Program for hosting such great sessions for us to all stay up to date with the different topics. And then also thank you all for joining today. whether you're listening into the live session right now or watching the recording after the fact, I really appreciate your time in giving this topic the attention it needs. This year, actually, past year has been seeing quite a bit of change, both from the policy and research perspective. And so, as a pharmacist, of course, as Tara mentioned, spent a decade working with health systems, uh, inside and out of health systems, bridging the gap with the medication use process. And so, I feel like I'm intimately aware of some of the challenges clinicians face when trying to navigate safely and effectively prescribing medications. So whether you're a provider or administrator, or in any way related to the provision of telehealth services, I hope some of these insights are useful for you and give you a better understanding of prescribing rules and regulations in telemedicine. So of course, we've got to do our little disclaimer here, and any information, of course, provided in today's talk is not to be considered as legal advice. It's purely for informational purposes. And I'd like to kind of walk us through going through this session in three sections. So really understanding the landscape as it relates to the rules and regulations with prescribing. And then we'll kind of dive into some of the emerging trends and challenges in the industry at place today. And then we'll kind of briefly touch on some of the potential technologies and even maybe practices that may influence this. So let me start by asking all of you in the audience, when you hear the term house call, what first comes to mind? What would you imagine it to be? And it's a question I actually asked ChatGPT earlier, so I could come up with a picture for this slide. But I thought it was fairly accurate. So by definition, house call refers to a medical visit where a healthcare provider travels to a patient's home and delivers medical care. So for the very first time, around this time last year, in fact, I actually got to witness this firsthand. I actually had to take an emergency flight out to India, while my 80-year-old father-in-law was navigating his care, and he's pretty frail at the time, and so we actually took a flight out, and I remember literally sitting in the living room, the family living room. They live in this high-rise building in the heart of Mumbai, and it's a very small space. So I was able to see multiple providers actually walk in and make personalized care a reality for them. Um, I remember vividly actually remembering a provider going into the kitchen pantry and trying to assess if he was getting the right nutrition, and they found herbal supplements, and so they were able to actually really fully assess the patient, my father-in-law at the time. So thankfully he's better. He's at baseline now, but this kind of goes to show, historically, house calls were commonplace here in the US at one point. And, while they become less common, there's this kind of renewed interest to leverage telemedicine to get a better picture and understanding of the patient in their own environment. In school, we were often taught, let's meet the patient where they are, right? So now if you consider, and, we view telemedicine as a modern day house call, rather than ringing your doorbell, clinicians can, perhaps ping your smartphone or device. And that's, whether it's synchronous or asynchronous modalities. But for the purposes of prescribing, we're largely focused on synchronous consultations. And so that is where a patient and the provider interact in real time via a two-way video conferencing call. Now, there are some exceptions to that. In some cases, audio-only calls may be used for this interaction. Let's say in mental health, for example, where the patient may not have access to broadband internet, or they may opt out of using video for privacy reasons. But as we know, this is not a one-size-fits-all model either. There's actually recent research that was done that I'm showing on the slide right now, and it was done, based on different specialty areas. There's a few listed here, mental health being one of them, that saw this really high, utilization at the beginning of the pandemic. And, they've slowly sort of trickled down a little bit in some cases, but there's other specialty providers that really didn't have such a high growth adoption curve. And, those were maybe ones that needed more of a physical touch point during the patient encounter, like wound care or podiatry. But for the most part, we can safely say that telehealth is here to stay to some extent. And it really depends on the nuance of what specialty and practice you're looking at, as well as what type of use case, whether it's medication management or practice psychotherapy or what type of engagement are you having with the patient as well. So it's very nuanced. But, let's go back to prior to the pandemic. So really the adoption of telemedicine in the US was relatively slow prior to the pandemic. And it was largely the large healthcare providers that were the main sort of key players. It's a bit of a head nod here to these institutions like the Mayo Clinic, for example, because they really recognize the potential benefits of using telemedicine for patient outcomes early on. Now, we think of the reasons for the slow adoption prior to the pandemic really was attributed to a number of reasons. One of which was limited integration, of course, of technology within EHR systems and perhaps clinical workflows. There was also resistance from both the patient and provider. Patients had these perceptions where does the virtual call actually match or best the face-to-face interactions? And then providers also had similar concerns, and then also about quality of care issues and potential liability of remote care. So, these are frankly things that were dispelled as we started to, see higher adoption. Other challenges also were around reimbursement and regulatory policies that also may have contributed to slow adoption. And the latter is what we want to really dig into today, is the sort of policy piece. So let's talk about the overall regulatory framework or prescribing. So when it comes to prescribing, I like to kind of think of it as a balancing scale here. In general, the federal regulations, mainly the Ryan-Haight Act, governs the prescription of controlled substances with some state law variation within those bounds. And then each individual state also have their own rules for all of the other prescription drugs. Now, it's crucial for healthcare providers to be familiar with and adhere to both the federal and state regulations, and I often recommend using the most restrictive of the two to ensure compliance in their practice. So now let's focus on specifically on the controlled substance component and the regulations that govern their prescribing. So when we think about controlled substances, it's really how the law places these drugs into one of 5 schedules based on their medical use and abuse potential. So, for example, let's take, for example, Schedule 1 on this slide. For the most part, it has a high abuse potential, but it may have some minimal or zero accepted medical use. And so for the purposes of controlled substances, we're really more focused on Schedule 2 to 5. Now, the Controlled Substance Act of 1970 is a federal law that regulates the manufacture, importation, and use of these substances. And also, it's a good mechanism for drugs to be added, removed, and even transferred between schedules by the DEA and the FDA. And these federal agencies actually look at certain factors when they look at these drugs. What is the scientific evidence out there? Is there any public health risk? And maybe looking out for signs of history and signs of pattern of abuse with these drugs is important. So I'll take, for example, buprenorphine. Buprenorphine is a Schedule 3 drug, but when it was first introduced in 1985, it was actually classified as a Schedule 5 drug. And I think large part of that was, partly because it was new to the market, but also it was actually introduced as a low dose formulation at the time. So it was seen as a relatively low risk drug. Now, I think it's important to keep 2 perspectives in mind here. One is the policy perspective. This is why research is incredibly important for us to do on these drugs and drug therapies, is because it allows us to guide decision making on how we actually classify these medications. And as we'll see in the session, the classification of these medications actually affects how we create policies, and that has a great deal of impact to access to patients. Also, from the operational perspective, it's important for healthcare professionals to know what schedule these medications are classified under in order to appropriately prescribe and also dispense these controlled substances. We really need to figure out how do we get these medications safely and effectively to patients, and how do they stay adherent to them. One thing I like to always kind of do is put on my pharmacist hat and say, dispensing is really just the two sides of the same coin. Prescribing and dispensing need to go hand in hand. And so, looking at some of these schedules, for example, Schedule 2 medications, a lot of my pharmacy colleagues kind of call this the one script, one fill rule. Whenever they see a prescription come in the pharmacy, oftentimes Schedule 2 drugs do not have any refills. And so, that's an access issue perhaps for a patient. And these things are, nuances that we need to acknowledge as far as how do the patients get their medication and, again, stay compliant with it. Now, while the Controlled Substance Act provided enough protection to patients, it wasn't until the internet came along that changed this dynamic. So before 2008, online prescribing of controlled substances was relatively unregulated. And this really led to concerns about illicit distribution and fraud through these online internet pharmacies. It was sort of a wild west of the time, actually. So we had providers, writing blanket prescriptions for patients, and we had, mail order pharmacies sending out these drugs en masse to the public. And this was really a big patient risk issue. So, in short, this really resulted in the Ryan-Haight Act coming about. And this act immediately shut down a lot of these sort of pill mill, sort of, I call them the cowboy operations at the time, because it required the provider to first conduct an in-person visit. Now, unfortunately, today it sort of has a unintended consequence. It prevents legitimate prescribers from using telehealth simply write prescriptions for controlled drugs for their patients. Now, the Ryan-Haight Act, has a few exceptions. I've listed them here. And I wanted to highlight just a couple that are, more important today in regards to policy. And so one exception to point out is number 5, which is the special DEA registration. Now, this has been largely left incomplete since its conception, but the expectation by many here was that it would enable providers to prescribe controlled substances through a telemedicine-only pathway. This has actually picked up a lot of steam recently in discussions for advocacy around new policy changes. Another exception to kind of point out here is this in-person requirement being waived during a public health emergency. And this is kind of what we saw during COVID. It was implemented during the pandemic by the DEA in order to prevent lapse in care and to sort of, prevent a larger burden on the healthcare system overall. Also, as we'll cover in the next section, the DEA has released new proposed rules, which fall under this very last exception. I call it the other category. And I'll kind of let you decide, when we cover this, I'll let you decide if this actually serves to expand access or not. So as we mentioned earlier, while the federal government establishes a foundation for prescribing regulations at the national level, states often address their own set of rules and requirements for remote prescribing for both controlled substances and non-controlled substances separately. And the next few slides will kind of focus on non-controlled substances, but I've listed a few of the criteria here that medical boards use to govern and enforce these rules. So in general, if a provider does have a pre-existing relationship with a patient, they are certainly going to have more flexibility when it comes to prescribing. But however, states do have their own rules and how that relationship is formed. And, is there a physical examination required? Or if there isn't, what are the requirements for the evaluation via telehealth? And so if you look at this map, you can see half of the country, that's about 25 states here highlighted here, actually do not allow providers to establish that physician-patient relationship via telemedicine alone. And so you have to always keep in back of your mind that these interactions are always governed by the law in the state which the patient's located in. So for providers, it's essential to be familiar with these state laws, especially if providers are practicing in multiple states. Now, also, just to kind of review some of the patient examination requirements in states that more thoroughly describe what a telehealth evaluation looks like, they commonly list the following, which is, is there a medical history taken? Is there a diagnosis given for the patient? And, is there a therapeutic plan or workup? And then also ensuring the availability of follow-up care, whether it's in person or otherwise. And, just to point out, in states that don't specify this exact requirement of an exam, the default may be to provide the same level and standard of care as given in an in-person evaluation. Now, there are also exceptions. As far as exceptions go, in different states, states can and do adopt specific limitations on what medications can be prescribed via telehealth. And most commonly, what we do see are medications for abortion-inducing drugs and medical marijuana, but some states do list other categories. In South Carolina, which is where I'm based, their finasteride is a drug that's barred from telehealth prescribing. I'm not really sure why, but these express exceptions do exist. So it's important for providers to be familiarize themselves with both the baseline laws and these express exceptions. And many of these exceptions, by the way, are may not be easily found in the state regulations. So again, this is another reason why it's good to have legal counsel to navigate some of these, uh, smaller details. Now, other exceptions include asynchronous online questionnaires, which are becoming more common. So I'm sure you've seen this with direct to consumer telemedicine companies in the recent past. You may kind of stumble across a company that has perhaps an online form that you fill out, and then go through this decision support system, and you perhaps have identified a drug to be given, and that's sent out to you by email or by mail, sorry. And so it's one of those things where you know providers really need to be cautious about some of the state laws around these types of processes, because in most states, static questionnaire by itself is not a really sufficient basis for a prescription. In fact, 36 states explicitly prohibit this. So it's likely more actually also prohibit this in a less obvious way according to their regulations. But I think it's a move towards a positive direction. This really ensures that there's a sort of a guardrail to patient safety, first of all. And then secondly, it ensures that, the patient provider relationship remains intact, because really that's the core of healthcare. And, making sure we don't automate all the process, I think that's important to kind of acknowledge. Now, before we move to the next section, the last thing I wanted to touch on is interstate licensure, which has become a significant burden and a very contentious issue for providers. So this is mainly because the traditional licensure model mandates providers be licensed in the states that the patient is located in, as opposed to the states that providers are located in order to prescribe treatment. And so I was actually speaking to a psychiatrist, a friend of mine, the other day, and he shared with me how challenging it was to follow up with care for his patients. Many of his patients were college students, and so while they were away from home in a different state, this was a bit of a barrier. He actually expressly said, um, obtaining licenses in every single state really isn't a feasible option for him. So some of the ways that have come about to alleviate these challenges are licensure compacts and registrations specific to telehealth. In fact, several states have this in place. And then there's also limited exceptions in some states as well that exist. While I was doing some research, I noticed that Kentucky, for example, has a special carve out for visiting sports teams. So interesting enough, if you're a doctor employed by a sports team visiting Kentucky for a sports event, then you're allowed to treat the entire team without a Kentucky medical license. And there's also similarly this also federal legislation that passed in 2018, in fact, that ensures sports medicine doctors who work for sports teams can treat athletes across state lines. So it really makes you wonder, if athletes are able to get treatment by their preferred doctor without them being licensed in the state, shouldn't this be a privilege for everyone? So since we're midway into the presentation, I just wanted to shift position here and kind of look into what are the emerging trends we're seeing today, and also look into some of the challenges along the way that we've kind of observed. So the pandemic inadvertently gave us insights into what would happen if we loosened regulations. As a result of flexibilities that were introduced, such as waiving the in-person requirement, along with increased demand for remote healthcare, we actually saw a huge rise in telehealth startups during this time. Now, I will say, they did demonstrate a lot of benefit to the public good. Access to patients was incredibly important at a time when social distancing was a priority. However, we also saw, and I'm sure some of you, in the audience, noticed the large amount of media coverage some of these companies got around inappropriate prescribing at the time. Some of them were actually, in the case of Cerebral, for example, were overprescribing stimulants for patients with ADHD. And so, there was this fear of being audited, so much so that, retail pharmacy corporations stopped, dispensing drugs from select companies and leaving patients stranded at the time as well. And this chaotic period gave us an insight into what are some of the negative consequences that could occur without the right checks and balances in place. Now, around the same time, we also had many deaths from overdoses involving opioids, particularly synthetic opioids, which is still continuing to rise in our communities. And, this is despite strong evidence that medications paired with psychosocial therapy are really a gold standard for treating opioid use disorder. And so, I was just looking into some of the statistics, and, I came across this one that was very prominent. Only 1 in 5 Americans actually receive the treatment that could help them quit and stay in recovery with these medications. So I think telehealth flexibilities really open the door and enable providers to treat these patients who would normally otherwise become just another statistic. Now, while we had federal loosening of flexibilities in place, many states also had similar provisions to enable access to these life-saving treatments and medications. However, frustratingly, Alabama threw a bit of a curveball. So in the very beginning of the COVID, they actually passed a law preventing clinicians from prescribing controlled substances without having an in-person visit. And so as a result of this law, a company called Bicycle Health, they're a telemedicine company based in California, actually had to inform its patients in Alabama of this new mandate. And, less than 3 months before the deadline, when only 20% of the patients were able to find a local provider, to avoid sort of just mass discontinuation of care for these very vulnerable patients, Bicycle Health orchestrated what is now known as Alabama Airdrop. And so in July of 2022, the company flew two Alabama licensed physicians to Birmingham, where they met with approximately 300 patients in a hotel room for over 3 days. And this allowed the patient to then continue their treatment for another 12 more months. In fact, this was actually repeated last year as well. And so it's surprising, this is a great example of how a state law that's intended to protect the public had actually created a barrier to access. So in the last slide, one of the main reasons for Alabama airdrop, why it was implemented, was that there was a shortage of local providers and psychiatrists with these prescribing privileges. And I think part of the problem here was due to an archaic federal policy that existed to prescribe buprenorphine for 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 patients. And that was really due to the Drug Addiction Treatment Act, which mandated that providers jump through a number of hoops, going through a number of training courses, providing notice of intent, and a number of other steps to obtain what is called an X waiver. And so that's really what it amounts to is earning an X by your DEA license, so that you have the credentials to be able to prescribe this drug. It also had other restrictions, like limiting the number of patients that providers could see every year. And, I would say after almost 2 decades of this legislation, only about 6% of providers, that's approximately 100,000, just over 100,000 providers, actually, signed off on getting this modified waiver. So the uptake wasn't very great for 2 decades, essentially. Now, the X waiver requirement was removed last year, thankfully, but some say it may not be enough. In fact, we have research now that points to other barriers that still exist with this. So there's a lot of work to be done still. Now, moving on to when the more of today's where we are today, when the public health emergency finally ended in May of last year, the fear, I think, for most of us was that some of these temporary flexibilities that were granted would expire or simply be phased out. And so the DEA took a bit of a proactive stance here. They published two notices of public rulemaking, and these were to expand prescribing of controlled substances via telehealth, with some restrictions, of course. Now, the outcomes of these proposed rules, which we'll cover in the next slide, haven't been finalized yet. But I think this was a really pivotal moment because, we had, I think, 38,000 plus comments that were received and reviewed by the federal agencies. And I think because of this, because of the advocacy as well with our telehealth resource centers and the AT and other organizations, there was this temporary extension that was issued, which effectively gave us 1 year grace period for some of these flexibilities. Now, these flexibilities will be sunsetting at the end of this year, but I think it's important to recognize that this gave us an ability to avoid lapsing care in patients and to avoid overwhelming, again, the health system in general. So the two new options introduced in the proposed rule are a virtual first process and a qualified telemedicine referral process. So the virtual first process is where a provider can issue an initial prescription for controlled substances without having conducted an in-person exam of the patient, but only if certain criteria are met. So one criteria is the medication has to be a non-narcotic, Schedule 3 to 5 drug or buprenorphine for opioid use disorder, and the prescription cannot exceed more than 30 days supply. So, we can kind of call this perhaps a telemedicine prescription. Now, the caveat to this is, the patient, if they do need a refill beyond the 30 days, they may need to undergo an in-person examination. Now, the second option, the qualified telemedicine referral process, is where a patient has an initial in-person evaluation with a provider who then refers the patient to the second provider. And then this second provider can see the patient and prescribe them any schedule of a controlled substance without actually personally having an in-person visit with them. So compared to the original Ryan-Hay Act, these two new options are surely expanded flexibilities, but in my opinion, they're still more restrictive than what has been allowed in the past few years under the public health emergency waiver. So I think the jury's still out. I think we need to decide, is this good enough, or should we advocate for more expanded access to patients? Now, on a separate note, there was an update at the very beginning of this month, and Professor Sklar and team were kind enough to let me introduce this into the slide deck last minute. But I think it's a great update, which is the Substance Use and Mental Health Administration, SAMHSA, actually announced a final rule updating the regulations regarding the opioid treatment programs, the OTPs for short. And these announcements, I think, were the first of their kind in over 20 years, and major milestones here to increase access to medications for opioid use disorder. So during the pandemic, these flexibilities were implemented separate to the DEA's Ryan-Hay Act waiver, and primarily they were to exempt OTPs from the in-person exam requirement for patients being treated with buprenorphine. Now, also just to note, around this time, this flexibility wasn't actually applied for methadone. The final rule, however, allows OTP providers to initiate treatment of both buprenorphine and methadone via telehealth, which is big news. Now, the key difference here is the audio-only modality may not be used for methadone, and I think part of the reason was it is a Schedule II drug, and so the perception is it may hold a higher risk profile. But there are a number of other flexibilities, and there's a laundry list of actually other uh, restrictions that have been loosened from this final rule. So I think this is, I won't be covering that today, but I think this is a very positive movement. And it shows that, there's a very progressive stance from policymakers towards better harm reduction strategies overall. Now, one last note before we wrap up this section, the TREATS Act was actually reintroduced and is in the Senate as of November of last year. And this bill seeks to permanently allow providers to prescribe opioid use disorder via telehealth. So this kind of goes beyond just opioid treatment programs, the OTPs, as we discussed in the last slide. It would actually amend the Ryan-Hay Act to allow buprenorphine treatment via telehealth visits without an in-person requirement. So as we wait for permanent rules to be finalized this year, this is certainly one that we do need to track. So I have a few slides that I want to share very briefly from the technology perspective. Now, the key concerns from policymakers and law enforcement alike have always been around protecting the public, whether it's for drug diversion or it's around fraud. These issues do exist, and we can't close our eyes to them. But at the same time, their role is to carefully balance access to drug supply, but also, prevent bad actors from taking advantage of these very sometimes loose regulations. And so this is where I think electronic prescribing and prescription drug monitoring programs enable us to track and monitor these issues effectively, and perhaps even mitigate some of the gaps in the process. So recent efforts to mandate the use of e-prescribing technology and integrate PDMPs into electronic health record systems have been moving in the right direction. And we've certainly seen an increased adoption over the last few years. In fact, looking at September's data, 36 states have actually implemented electronic prescribing in some form or fashion. And then with PDMPs, we've actually got all 50 states that have successfully implemented their own programs. Now, this is great news on the outset, but if you look at this through an operational lens, this is kind of where things get a little bit fuzzy. So, speaking with some of my pharmacy colleagues, for instance, if you were to, in the past, if you were to go to a retail pharmacy and, they were unable to, for some reason, they were unable to fill out e-prescription for a controlled substance. Perhaps they didn't have it in stock. Perhaps there was a drug shortage. This actually couldn't be transferred to another pharmacy that did have it available, even if the pharmacy was from the same company. And so, this is interesting because, if you were to bring a paper prescription to the same pharmacy and it was for a controlled substance, the workflow would be a lot more simpler. The patient would actually take that script back from the pharmacist, and then they would go to another store and get it filled. So it's kind of fortunate that the DEA's final rule last year will now allow a retail pharmacy to have this flexibility to transfer initial prescriptions one time. But the question, still remains, will these different pharmacy systems be able to speak to each other? Are they going to be able to be compliant with this policy, or will interoperability gaps still remain in the process? And then also, just one last thing to mention here with the prescription drug monitoring programs. While their purpose, primary purpose is to support audits and to prevent diversion, there are some limitations that still exist today that we need to really talk about. One is, how proactive or reactive are some of these PDMPs? I've come across some states that actually have, their medical boards only review events after a patient or a provider has reported an issue. And then there's some states that are actually more proactive and they actually have a better reporting system and they may have refined algorithms to detect issues as they occur even. So, each state is not standardized and maybe in different levels or different stages of their program. Also, research has shown that providers conduct interstate reviews less frequently in different states. And so they may actually miss data on patients who have failed medications, for example, in neighboring states. And, this leaves a question mark of like how reliable and accurate is the information that we're getting from the databases. And then lastly, the disruption to the clinician's workflow is still significant, even though some of these systems are integrated into EHRs. I've just kind of found that my colleagues tell me these workflows are very clunky, very cumbersome, and they do take time out of the schedule. So I think as these technologies evolve, my hope is, they become more intuitive, and they also serve to be proactive tools to seamlessly identify risk for the clinician and for the provider at any point in the patient's journey. So what is the future outlook? Well, this year is important, certainly from the policy perspective in general. We don't want to take a step backwards. We want to move forward in policy perspective, particularly in regards to establishing permanent rules around prescribing in telemedicine. We also have a bit of a way to go with licensure and regulations, particularly when it involves interstate practice. And I think, in my opinion, really no patient should be left behind when it comes to, their geographic distance, lack of transportation issues, or any other privacy concern. We really need to be patient-centered with these policies. But ultimately, as we consider expanding access to medications and improving harm reduction in our communities, we really should be proactive in conducting research that continues to inform and shape our decision-making abilities, especially with policymakers. And so I'll stop there. And maybe we can start taking questions. But thank you for listening in.
Oh, that was wonderful, Dr. Shaw. What a great overview to help us explain the context of how we got to this point in time. Yeah, so yeah, when you have a moment, maybe stop sharing your screen and we'll go, yep, perfect. And we'll go into the Q&A. We had quite a few questions come in during your talk. And as you know, you and I also had some back and forth on issues, evolving issues in this area that is quite confusing and really unfolding in live time. So one I want to touch on right away, because it really speaks to the licensure issue that you were concluding with, was from Cynthia, who's listening in. And she asked a pretty essential question here. Could you please clarify whether a prescriber is held to a law in the prescriber's home state or in the state where the patient lives?
Yeah. I think for the most part, the answer is where the patient's residence is. And I think it does get a bit sort of fuzzy, right? Because if you have patients who have, maybe retired and they have second homes, or perhaps they're college students and they have, they're sort of transient. I think that's kind of where it gets a little bit murky. But technically, it's really where the patient resides is where the licensure, needs to kind of be um, you know, be had by the provider, I suppose. And so I think this is kind of interesting because what has been established very early on, even before we had technology in place, or telemedicine certainly in place, these laws were sort of you know started when in that sort of era, in a different era, I would say. And I would sort of suggest, how can we rethink this? How can we kind of reimagine like licensure models? Um, should some of the ideas I've heard in the recent past have been, shouldn't we license, or create licenses based on where the provider resides, or the primary site of the provider? And these are questions that haven't been answered, but I think it's ones that we should be asking about for sure.
That's great. I know I was so tempted in the chat to respond with essentially at the core of the issue, which is where the patient resides, but it is much more nuanced than that. And I really love how you pointed to the context of it because historically it is the state that has oversight over the practice of medicine in that state. And at the core of that is to protect patients from potential harms, including from these out-of-state providers coming in. But in reality, you end up with all these scenarios of retirees and college students, and so all very applicable. And I think there's also this element that gets to this chilling effect, right? Where you maybe as a provider, you want to provide care where the patient resides, that a fear of losing your license in your own home state, the implications for your own patients in your state and your own practice. So all great insights and great questions, a great question that gets to the core of so many of these issues. The other one was regarding, and I think this in some ways relates to the recent SAMHSA rule that just got published. Can any provider prescribe buprenorphine to their patient via audio only? Or does that provider have to be under a certified opioid treatment program?
Yeah, so I need to actually read through the entire final rule because I think this is
I,
really, really interesting. As far as I understand this, it's really, the scope is within the OTP provider. So really within that sort of section of opioid treatment program as it relates to the provider. But one thing I did sort of take away from the final rule is, the definition of the provider or the prescriber is actually changing. So it actually may expand to other types of providers, and one certainly being pharmacists. So I thought that was interesting because if we can expand access to buprenorphine, particularly in this sort of time where we have physician shortages and perhaps, provider shortages in general, if we can expand care by using other providers like pharmacists, for example, as ways to extend access to these medications. I think that may be a good opportunity in the future. So the definition, again, the definition of prescriber is goes by whatever state you're practicing in. But I think it's important to recognize, there's potential for expanding access to care.
Yeah, that's great. I I put in for our listeners the actual rule on the Federal Registry if you'd like to see it for yourself. We also have
Perfect.
a we also have a blog coming out on the topic. And to Dr. Shah's last point there, it is an expansion of access to care to think about these extenders with nurse practitioners and physician's assistants being able to prescribe buprenorphine under that final rule. So please take a look at the actual rule and on the lookout for the a blog dissecting it for you is coming out very soon. One of the things that I think is so what's the word I'm looking for? All kinds of theories about what could be happening going forward with the DEA is on the special registration pathway that you mentioned when you talked about the possible exceptions to the Ryan-Haight Act. So I know you touched on it, but maybe because that is so pressing right now with how the DEA may respond going forward, maybe sooner than later, given uh, given the huge onslaught of comments they received the last time that they proposed a rule. So, what are your thoughts on the special registration pathway?
Yeah, yeah. So I actually, I have a few thoughts. It's interesting because I hear that there's rumors on you kind of work being done with the final rule. And I hope this is as going to be a big part of it. But with special registration, I sort of look at is, how can we actually operationalize this so it makes sense for both providers that are prescribing and also for pharmacists who are dispensing drugs. Because, if you look at the data act, right, and sort of the X waiver that we had for prescribing buprenorphine, it was literally a similar modified waiver. We had X by the DEA license, and this is an instrument basically of how providers could prescribe this drug. Now, if we're looking to do the same thing with special registration, consider it as sort of a modified waiver, have, let's say, T for telemedicine, right, stamped on the DA license. Um, you know, my first consideration is how much of a barrier will this be for providers to actually get that waiver in place? Is it going to be like the X waiver where we have a very low utilization of it? Or, will this be an easier sort of thing to implement? So that's one concern I had is, what are the barriers in place to actually have a special registration in place for providers? And then the second piece is, how do we make sure that these the special registration is actually recognized by our pharmacists who are dispensing medications, because when I speak to my pharmacy colleagues, it's there's always concerns about out of state providers prescribing these controlled substances. Sometimes they're looked on as sort of like red flags, and you know I think it's important for us to recognize that pharmacists are very much part of the harm reduction strategies. They're very much involved with patient care and they want to do the right thing. So, how do we create perhaps a safe harbor for pharmacists, not to get investigated by DEA, not to get penalized by law enforcement, but actually be able to dispense some of these drugs? And I will say one thing that I did learn about very recently, which I thought was insightful, was when pharmacies actually order some of these drugs, like buprenorphine, for example, and maybe there's some variation in how much they order at any given time. The wholesalers actually have a threshold limit on the quantities that they order. So if it reaches a certain threshold, and over a certain limit, it triggers an alert to law enforcement to then perhaps make some investigation. So there's, it's not that pharmacists don't want to dispense. It's just that there's a fear of dispensing and being being audited by some of these agencies. And I think so. So just making sure that we have a well thought out process for special registration, I think is going to be important. And how do we operationalize that, right? So.
Oh, that's great. That's very nuanced and very interesting to think about the safe harbor in addition to a registration pathway. And that's very insightful. Thank you. In our remaining time, and you kind of alluded to this a bit potentially. I mean, you did in your talk as well, but we just have in this space, you also have potentially some bad actors and some concerns with how people receive medications, particularly filling out an online questionnaire and getting them in the mail. So we had one of the participants type in, folks go on to these performance anxiety online websites or anything that, it's more about like productivity websites to get these certain medications that some of which are controlled substances.
Mm, mm,
So what are your thoughts on how to regulate that? Because it does really enter this interesting gap where the telehealth companies really aren't being regulated in how they're advertising some of these products because the FDA can't do it because it's not an actual drug manufacturer, it's a telehealth platform. And the FTC
mm.
can't do it because they aren't actually misleading ads necessarily. They're just not weighing the pros and cons and the side effects like they would if they were a proper drug company. So, yeah, what are your thoughts on that?
Yeah, I mean, there's a lot of again, the cowboy sort of Wild West scenario, right? We also have social media platforms, right? And how are we kind of regulating perhaps influencers on those platforms that technically may be advertising these drugs? It's definitely this could get really into a rabbit hole, but I think one thing to just kind of bear in mind here is um and I think we've seen this during COVID with some of these uh, companies that were overprescribing or seemingly inappropriately prescribing drugs. Um, you know, is that clinicians are essentially the gatekeepers for medication access, and so I think it goes back to clinical judgment and good best practices by clinicians that can perhaps help mitigate some of these issues. I will say, just speaking to some colleagues with with sort of in the context of ADHD drugs and some of these more popular drugs that are being supplied, there is a trend towards more prescriptions, but we've got to ask ourselves here, what is the evidence behind this? Is this legitimately due to some issue in the system, or is it legitimate prescribing because of better access to care? We have to do the research behind some of these statistics and not just kind of take it at face value. So I think those are my thoughts.
Oh, that's great. Thank you for that. Well, I think we are quickly wrapping up, so I'll turn it to Melanie Escher to take us home. Thank you so much.
Great.
Okay,
Thank you
thank
very
you.
much, Dr. Shaw, and thank you very much, Tara. It's always fun having you participate in our webinars from the East Coast. Like I said, I'll be sending out a thank you email to everybody that participated today, and I will also share some of those URL links that Tara had put into the chat so that you don't have to worry about trying to copy them down right now. And any information about requesting your CME certificates or certificates of participation. Thank you again for joining us, everybody. And if you have any questions, you can respond to my email once you get it in a little bit. And I can forward on any more questions to both Tara and Dr. Shaw. Thank you, everybody.
Thank you. Take care.